Hello and welcome to HIMSS TV. I'm Susan Morse, Managing Editor for Healthcare Finance News. We are here today with Dr. Donald Rucker, who is the National Coordinator for Health Information Technology at the ONC, and also with Dr. Kent Locklear, who is CMO for Lightbeam Health Solutions. Welcome to you both. And we're talking today about the interoperability rules that came out and how they affect healthcare. And I wanted especially to ask you both about how these rules are expected to impact population health. And I know, Dr. Rucker, that has been a topic of very much of interest to you, and Dr. Locklear, that's the basis of your business model. Would you like to go first, Dr. Rucker?
I think the big fact of population health is we spend, unless we're really sick, the vast bulk of our time living our lives and not immediately in the delivery system. So how do we, what are the technologies that, the modern technologies that allow us to take better care of our bodies ourselves, as it were, in a digital way? And so what has been very important, and what ONC, one of the staff agencies within the Department of Health and Human Services, we've implemented Congress's 21st Century Cures Act provisions requiring electronic health record vendors to have standardized APIs, that apps that we could have on our smartphone get our clinical data, so they can combine that with whatever the app is bringing to the table on the one hand, and then the requirement that providers are required now under our rulemaking based on the 21st Century Cures Act to give us our medical record data in a digital form that is under our control. So all of a sudden, we're moving, and these things take first effect in the next 2 years. But all of a sudden, we're moving from a state where we have to have all interactions really gated directly, almost in an on-premise kind of way, with a modern digital way where we can be in constant communication or monitoring in much more seamless ways. We think that's going to be at the absolute pivot of rethinking population health. I'll let Kent talk about all the analytics that will backstop that as well. So let me turn it over to Kent.
Yeah, thanks, Don. Your observations are spot on. So much of what we need to understand from a population level is occurring out in the world. It's not a part of a face-to-face interaction. I do spend part of my time still seeing patients. That's why I'm dressed the way I'm dressed today. And I'm working in a safety net organization. And so all of the challenges in regular life that our patients are exposed to are not always readily available to us in a face-to-face encounter. We're focused on their medical condition. There's, as in any situation, there's limited time. The population health tools that we provide as Lightbeam give us the ability to look deeper into the situation with these patients, particularly underserved patients. We're gaining more and more information related to social determinants. We're gaining more and more information about how to engage these patients in meaningful ways other than just in face-to-face. The COVID crisis brought this to full fruition in a very short period of time, when literally hundreds of thousands, if not millions, of encounters were canceled over a very short period of time, and people were suddenly lost to follow-up. And we were able to use our tools to identify those patients who had encounters canceled, who had existing care gaps, meaning they had important health milestones that had gone unaddressed. We were able to use our tools to help our clients identify those patients, reach out to those patients, use new technologies like telehealth, like secure text messaging, It's just all of these technologies are now coming together in a way that's very meaningful. And the ability to have reliable data, to have that data be accurate and to flow freely using these new standards and these new requirements that are being put forth by the ONC and the CMS rule are just going to really revolutionize, I think, this whole data situation.
You just mentioned how COVID has brought to light a lot about the underserved populations. I'm wondering if you can expand a little bit more about how these rules will help those populations. How will they be engaged to use these apps and get this information? How do you see this as working at the patient level and connecting with them?
It's surprising, even in our most challenged population. So we have a lot of homeless folks that I take care of in my clinic situation. Even those folks, many of those folks have a smartphone. It may be an older model, but they have a smartphone because in this day and time, that's the way everyone has decided we're going to stay in touch with each other. And so, because the smartphone technology is so prevalent, even in challenged communities, it's a tool that can be leveraged to try to improve their overall health situation. And with that, I'm going to turn it over to Don, let him comment about where this whole effort is going in terms of using that device concept as a linchpin.
Yeah, thanks. I think when you look at the apps on your smartphone, right? Go do the exercise and look at the apps, right? Like maybe when you have to clean off some because there's just too many, right? What you're seeing are a whole series of new ways of looking at the world, interacting with the world. What you're also seeing is that we have almost nothing related to healthcare, and the healthcare things we have, maybe a fitness app or a diet app, really don't incorporate medical information in them, right? Our actual medical information, our illnesses, for the most part. There are some exceptions, but for the most part, they don't. And so our ability in the future to get our medical information in is, I think, going to be the very beginning of an entire new world. In the rest of our lives, the balance between bricks and mortars and virtual has been transformative. And you see that everywhere, whether it's entertainment, whether it's travel, whether it's banking, whether it's shopping, right? Those balances have been transformed. Now with COVID, we've obviously had lots of telehealth. So we've had sort of a narrow gauge, piecewise rejiggering of it. But even there, it's still sort of same old kind of office visit, remotely type of thing with just less infrastructure around the office visit for the most part. That's a very narrow view of what apps and this modern economy are going to be. I think there are going to be all kinds of mixes of patient data, information for patients, monitoring, self-monitoring by patients, different ways of interacting with providers, automation around those things. And they're all, I hope, going to be part of a rubric where patients get a much better deal for their dollar. The American public has gotten a very, very poor deal for the vast amount we spend in healthcare because it's not really in a market economy. Really, they're conversations between payers and providers where we as patients and as a public have no control and very, no agency for all intents and purposes. Smartphones and apps and the web have disrupted many of these sort of sweetheart kind of arrangements. I would be stunned if this kind of digital transparency doesn't transform clinical care, and it'll transform it both on the product and the price of the clinical services. So yeah, they will be, I think you will see an entrepreneurial wave that has been pent up since we started doing healthcare the way we've been doing it since essentially the start of Medicare. Now, obviously, the digital economy doesn't really go back that far, but I think it's going to be quite interesting to see people compete for patients, health mind share and health dollar.
Yeah, you talked about the data, and we've all heard about hospitals just being inundated with data so much that it's a question of what to do with it all. I'm wondering, once all this data becomes shared with the patient, will it generate better data? Or will it be something, I mean, how can they filter out what they need to know, what maybe they don't want?
Yeah, that's where competition comes in, frankly. There are already some amazing computational tools in the rest of the economy. If you look at things like natural language processing, maybe first and foremost, neural net classification engines, there are all kinds of modern computing technologies that allow filtering of data, discovery within data, highlighting of key parts of data. Look, on some level, we're bombarded with it every single time we, hit the internet and have custom created marketing for us. Those people wouldn't be paying, Google all that money if they didn't think they were getting something from it. So we already have some pretty big proof statements in the rest of the economy that there are analytic tools that can customize information. So what you're going to see is that type of analysis coming to healthcare. Some of the same tools in our role on something called bulk data, bulk FHIR data, FHIR being Fast Healthcare Interoperability Resource, the rapidly emerging health data standard, are going to allow providers to sort through and gain insights. You've heard all this stuff about big data. The dirty secret of big data in healthcare is it's not that it couldn't be there, it's that it isn't, because you can't really get it. And you certainly can't do it as comparisons across providers because there haven't been APIs. So every big data thing you've ever heard of has been a massive one-off custom programming effort. With the ONC Cures Act rule, you're now you will have in certified EHRs APIs where folks can get at that. Now, if it's somebody besides the provider, huge privacy protections. This has to come under the HIPAA treatment payment operations. They're signed contracts. There are all kinds of data provisions. And obviously, if patients are accessing it, there are all kinds of privacy and security provisions and enforcement there as well. But big data is going to be transformative. And one of the things that we hope are, frankly, part of the reason we're doing this is with Lightbeam. So companies like Lightbeam, other population health companies, any analytic company in the country will have richer, cleaner, more actionable data so they can add more value on the calculation and the insight rather than having to spend resources to duplicate just basic data ingestion. I don't know, Kent, does that make sense?
Oh, it's hugely important. I couldn't even begin to give you an accurate estimate of how much time we spend and have spent in acquiring particularly clinical data to make sure that it's reasonably complete, reasonably accurate, and consistent. And unfortunately, every single almost instance of an EHR, EMR that we go to, there are all of these idiosyncrasies, all of these particular situations that have to be taken into account. Even with a standardized HL7 interface, there's still all of these because flexibility and configurability was always viewed as a positive in the EHR space. It's a double-edged sword. It's great for providing all kinds of different options for entering data. On the other side of that, when you try to harvest that data, it creates all kinds of complications. The data that you want is in different places, in different formats, with different kinds of sometimes standardized, sometimes completely non-standard codification underneath, it can be quite a quagmire. By creating these standards centered around the fire, the fire HL7 standard will allow us to remove a lot of that inefficiency and a lot of the challenges from that process.
Okay, thank you, Dr. Locklear. Dr. Rucker, thank you so much for joining HIMSS TV. It's been a pleasure speaking with you both.